Good morning, everyone, and welcome to this Philips sponsored symposium. Our speaker today is Dr. Leandro Slipczuk. Dr. Slipczuk got his MD and PhD at the University of Buenos Aires in Argentina. Following that, he did his residency at Einstein Medical Center and his fellowship in cardiology at Cedars-Sinai. Dr. Slipczuk is currently the Director of Advanced Cardiac Imaging at Montefiore Medical Systems. He's also Director of Cardiovascular Atherosclerosis and Lipid Disorder Center. He's an Associate Professor at Albert Einstein College of Medicine and also Associate Program Director of Advanced Cardiac Fellowship. Dr. Slipczuk today will talk about the use of Spectral CT in chest pain evaluation. Welcome, Dr. Slipczuk.
Thank you. Good morning, everyone. Thank you very much for waking up early, especially being in Vegas. I don't know how late you guys stayed last night, but I appreciate it. I'm very excited to be here and be giving this lecture. So we'll be talking today about the use of Spectral CT in chest pain evaluation and a little bit beyond that. So chest pain, we know, comes in many flavors. Patients that complain of chest pain can have stable chest pain, can have acute chest pain more in the ER setting, or even can have established ACS where the use of CT is a little bit more questionable, but sometimes they have mild troponin elevations, and CT can have a significant value in those cases as well. We know also patients that present with chest pain from cardiac reasons can be of many different types. Can be a typical male in the 50s, 60s, like we thought more before, but we know that female patients also have a significant incidence of CAD, and even younger patients. And we know even from what happened to Tim O'Donnell that if you like triathlon, I'm a fan of triathlon, and he was one of the world champions, and he had an MI during a competition. So before we would have said his exercise capacity is amazing, he definitely is good, he doesn't need anything, but it wasn't the case. So he probably had some plaque there laying down, and I think CT has a lot of value and a lot to add in these settings too. So we'll touch a few different topics. We talk about coronary disease. We'll talk about in the acute chest pain setting of a triple and quadruple rule out, aortic stenosis, patients with atrial fibrillation that can have a chest pain as well, and CT findings. And we'll touch base a little bit on cardiomyopathy. So probably everyone here is familiar with this slide. It's from Patel from American Heart Journal in 2014. So a few things have changed here. We can see in the black numbers the percentage of studies that are done in the US for each modality. And on the pie graph, we can see the percentage of patients that have these modalities showing significant defects that have obstructive CAD. Conversely, CT has a higher percentage with 70%, but it's still very underused, and part of that is because of training and people that are able to read CT. So I think SCCT has a lot of work to do in education to bring these numbers up. So hopefully also with the new chest pain guidelines, CT has a bigger role now, and you may agree or disagree in the cut of age of 65 that they chose, but I think the idea overall, not every patient needs a test. Use of calcium scores, or if you have a prior chest CT non-gated, you can look at that and see your pretest likelihood of having CAD. But I think definitely it's going with the data and is putting cardiac CT in the front line. We know that calcium scores have a lot of value in patients with that are asymptomatic for restratification to increase therapies or to decrease therapies, but also they have a value in the evaluation of chest pain, showing the burden of disease. And as per work from many authors, including Matt Budoff and Karam Nasir, we know that even there's a little bit questionable, especially in patients that have low to intermediate risk, a calcium score could be used potentially to rule out incidence of clinical events and obstructive CAD. But CT has a lot of value over this. We know from work from Mortensen that the more plaque you have, and even if you have non-obstructive plaque, that has a prognostic value. And in that way, I think there's a lot more value that that CT can add to calcium score. And this comes not only from obstruction. We can also evaluate the non-obstructive plaque, and we can, now there's multiple softwares available to do this, as you guys saw that were here yesterday for the AI meeting. But from work from Michelle Williams and Damini Day, we can see that if you have a plaque burden over 4%, at least in patients from the Scott Hart trial, the incidence of events is higher. So in that study, in particular in patients that were mostly white from the Scott Hart, the incidence of plaque burden over 4% was a predictor of events. And this is very important because imaging this plaque that is not obstructive, we can treat patients aggressively and hopefully try to decrease that rate of events. But today we're talking mostly about spectral CT. So spectral CT is not new. It comes from the 70s when the initial work came that you could use the data from different energy of photons to add value to your studies. And how this can be done is in different ways. We have a dual layer spectral CT like the Philips solution. The advantage of this is the spectral is always on. We can also have KVP switching where you have to pre-select a mode, and also you can have a dual source CT where you also need to pre-select. So the idea is that if it's always on, you don't have to pre-select patients, and KVP switching and dual source can have some other inconveniences as well. So we'll be talking mostly about patients that had CTs on the icon, but Philips has this new spectral imaging CT, the Spectral CT 7500, that has a wider detector, 8 centimeter detector, has a faster table that can help, and has some other functions that we'll be talking about for motion correction as well, amongst other things. One of the advantages, I think, from the spectral CT with the dual layer, other than it's always on, is that you get a spectrum of spectral results, having electron density, calcium suppression, C effective, where you get the atomic number. You get a virtual non-contrast that we'll talk more later. You can have iodine no water. You can have mono-E's to evaluate patients that have a low attenuation from maybe low contrast or poor timing. And you can also have the conventional scan. And this is all available for you to find it with post-processing according to what you need for the case. That sometimes you know from before that you may need these things, but many times you don't. So it's all there for you to use. So we'll talk about the different options that you get a little bit. So you can see on the left the mono-E's. These are images that show attenuation as if a single monochromatic energy was used to scan. When are these useful? If you scan a patient that the attenuation is too low, this can boost the iodine signal, and it can save a case that otherwise would have been non-diagnostic. It can generate improvement in the contrast to noise. It can reduce a beam hardening artifact or metal artifact reduction as well. Sometimes you know about these things, sometimes you don't. Your technologists scan the patient and then you have artifacts, so you can modify the mono-E's to help you get a good quality scan. You can use a virtual non-contrast as well that shows images as if the iodine wasn't there. We'll talk a little bit more about this later. We have also the iodine no water, iodine density. We have the C effective also that will show the effective atomic number. We can do calcium suppression as well, and also electron density and uric acid that we personally don't use as much for cardiac yet. So how will the mono-E's help you? So if you scan at 120 kV and then you can modify the mono-E's and create reconstructions, you can go to lower mono-E's, and in that way you will increase the contrast in your picture. But as you can see, you will have also some more hard beam artifacts. So that will increase those kind of artifacts, but it will increase your iodine, the iodine concentration as it was with a better trigger or a better quality scan. And if you have artifacts from beam hardening or metal, you can go to higher mono-E's, and in that way you will reduce that artifact. We can see here a case with a patient with a low radiation and low contrast dose. This patient had a CT with only 30 mLs of contrast. And I think We all do this. Sometimes it can be a little bit challenging if you want to decrease the contrast in some patients, and sometimes it goes well, sometimes it doesn't go as well. So if the contrast is not good, you can use, as you can see on the left, the mono is at 50 or 40, and in that way increase the contrast. And you can also see in the middle the C effective, that this, I think, will help you also to find sometimes stenosis, in particular if you're a little bit more under-trained or for your trainees to detect. But as you can see, it also will tell you about the composition of the epicardial fat and potentially composition of plaque. But you can go even lower, and this is hard. It can be done for every patient, but here's a case, for example, of a patient that was scanned with only 18 mLs of contrast, so very low contrast dose. That can be used in particular for patients that are skinnier. So if we have a patient that's morbidly obese, this will be a little bit more challenging. But patients that have CKD or you don't want to give a lot of contrast, you can do it with very low contrast concentrations, usually decreasing the rate of the contrast injection. But let's talk a little bit about the patients that come with acute chest pain. So we try not to use a lot of the triple rule out, but in some cases it can still be useful, I think. But this can be very challenging, as we know. Patients may have a faster heart rate, they may move a little bit, or they may not tolerate beta blockers as much, or you may not want to give beta blockers until you rule out certain pathologies, such as a PE. So the typical problem we have with this is the RCA. So the RCA, as you can see on the left, with conventional CT, you can have motion on the RCA, but when you use the precise cardiac from the newer CT, the 7500, this corrects for motion, and basically a scan that I think most of us here would say the scan on the left is non-diagnostic, and you may want to repeat it. You may have a diagnostic scan from that. This is from the same patient, and you can see that through the precise cardiac, you eliminate the motion of the RCA, and in that way you can save the scan. And the problem with this is if you have a fellow always in the scanner, or if you're always in the scanner, this is easier. But if you're not, if you have a high volume center and you're pushing CTs from many different locations, sometimes you may see this a little bit later, and then you need to call the patient back. So I think any solution that can decrease that motion of the RCA that we see sometimes is very valuable. We can see here another case. So the prior cases for the triple rule out, we usually scan helical. But here we see a case that when the heart rate is slower, we usually attempt to do step and shoot to decrease the radiation. But sometimes the patient's heart rate is well controlled, and then you put them on the table, you give the nitro, and that heart rate shoots up. So this happened in this case that was selected for step and shoot based on the heart rate, but the heart rate then shoot up to 77 beats per minute, so you see the motion in the RCA. But with the precise cardiac, you can eliminate that motion, and in that way also save that scan. So the precise cardiac has an algorithm where it uses a phase neighbor range and to pick a target phase, and creates through an elastic registration and motion estimation and through back projection the motion corrected picture for your scan. And this can be useful as well if you're trying to do, I don't know how many people here do perfusion scans, but if you want to do perfusion and you have faster heart rates and you want to look at the coronaries, this can help you as well. The motion correction may help you to have better images. But beyond the correction for the RCA, the spectral values, the spectral CT has a lot of value, I think, in the triple rule out. As we can see in conventional, in the top left, we can see this patient had pulmonary emboli, but sometimes this may be hard to see even if you have the perfect iodine concentration in the pulmonary artery. But we can see that with the C effective, the iodine no water, and the conventional, and the iodine density, we can increase the visibility of that PE, and we can also assess how large the PE is and in the perfusion of the lungs. So it helps us detect it, I think, and it also will help us determine how severe it is. We can see here more images where we can see the defect in perfusion in the lungs. And this can be also used for chronic pulmonary embolisms, where we want to see the effect of those chronic PEs in the lung parenchyma. But I think we now have more technology, and the delayed iodine enhancement has been used for a while, and we can see here a case that was presented and published by Gianluca Pontone, where we can see, in particular, I think this was very useful during the COVID pandemic that unfortunately hasn't gone away, but we can do a quadruple rule out. We can rule out aortic dissection, PE, coronary disease as a cause of the chest pain, but when we have suspicion that this could be also a myocarditis, we can do a delayed iodine enhancement. I'll show a case afterwards as well, how Spectral is useful for that. But it will increase also the detection of lesions, for example, like here. Here we see a significant lesion, obstructive lesion in the circumflex artery, that sometimes we may not know if that's artifact. Here I think it's a very clear case. But in particular, when there's hesitancy or we are not sure if the lesion is an obstruction or is an artifact, we can see that with the conventional imaging, it's hard to see that perfusion defect. But when you look at the iodine density or the C effective, this is very, very obvious. So I think in these cases also the use of Spectral can add value in perfusion. And we can use this in the acute setting, or we could use this when we evaluate patients that have ischemic cardiomyopathy, and we want to do perfusion, or we want to evaluate for the coronaries, so we can see the areas that are not well perfused, and we can determine, like in the prior case, it was most likely an acute event, the myocardium was not then, but we saw the perfusion defect. And we can also quantify the iodine concentration in those segments. As you can see in conventional versus when we do the iodine quantification, this could have extra value, but also makes it look a lot more obvious in the detection. But I think this has a lot more value in perfusion as well. And I'm sure you've had cases that you find also LV thrombus, in particular if you're doing patients more in the acute setting or patients with cardiomyopathy. And sometimes this may not be seen. Or sometimes we have to use also CT. We had a case the other day that there was a suspicion for LV thrombus. The patient had an ICD already, so we decided to go with a CT. And Spectral can help in this also in the detection, visualization of LV thrombus. In this case was an incidental finding, but it can also help our radiologist colleagues on the detection of these cardiac incidental findings. But also another thing that I think is very important and we like about Spectral is in lesions that are calcified. So when we have calcium, we know this can be a problem with CT due to the blooming of the calcium. And here we see a paper that was published in International Journal of Cardiovascular Imaging, where they found that they measured the stenosis with conventional and using Spectral CT mono E's, and they found a better correlation with the Spectral versus the conventional. I think it will depend in which cases you have also. You can say that you will need to use it for every single case, but if you have a case that has a lot of calcium, potentially you can decrease the blooming with the high energy mono E's. Or if you have a lot of contrast, if you ended up using too much contrast, you have too much Hounsfield units in the blood pool, you can also decrease that contrast with high mono E's. We tend not to scan too many stents, but many times we have a large center with a lot of referrals. Sometimes we don't know about the stent. Sometimes the referring physician wants to know about the other coronary arteries, not just where the stent is. So you're in a situation that you need to provide a report sometimes, and in that way you can use the high mono E's as well and the iodine no water to decrease that blooming from the stent. This still can be challenging. It's not the easiest depending on the size of the stent, and I think there's still a lot of work to be done to be able to read through every single stent. Potentially doing perfusion as well when you have stents can help in that. But in that way, the monoes can at least help you a little bit. So we see here another patient with a high calcium score. This patient has a calcium over 1,000. As we know from data from Dan Berman and his group, calcium over 1,000. Still CT can perform well, but it depends on what scanner you have, what patients you have, and where the calcium is concentrated. But when you have a bulk of calcium like this, it can be challenging. So this is a discussion we always have with the radiologists as well, on when to scan, when not to scan, according to calcium scores. And I think the answer is it depends. But in this case, we can see that through the use of high monoes, we can have a diagnostic scan, even with a big bulk of calcium in that LAD. We can see here the high burden of calcification of another patient with the Agatston over 700. And in this case, we can see also using high monoes and the C effective, you can clearly visualize a significant stenosis as well. So we'll talk now a little bit about virtual calcium scores. That is another function that we can have. So calcium score, I think, has a lot of value, not only as to identify if the scan will be diagnostic, but also tells you a lot about the burden of disease of your patient. So it means a lot for prognosis as well, as we saw from data from Mortensen and we know from many other papers. So, but what happens is that you need to do an extra scan. So we decided to look at the obese patients. We work in the Bronx. There's a lot of obese and morbidly obese. And obese patients have traditionally been excluded from many of the imaging studies. So we looked at the possibility of a virtual calcium score and how much the BMI would influence on that. The idea is that when you have patients that are obese, particularly morbidly obese, the calcium score can add some radiation. In our study here, we looked at 174 consecutive patients, and the radiation from the traditional non-contrast calcium score was over 2 millisieverts, so it was significant. So usually you do from the CT with contrast, you can do the virtual calcium score. You have to use a proportional constant to adjust for the typical non-contrast traditional calcium score, but we can see here a very good correlation between the traditional and the virtual calcium score. And you can see on the right the changes from the calcium score from the traditional versus the virtual after you apply the correction constant. But this is, I think, potentially usable for patients that have a normal BMI. It gets a little bit trickier when you have a BMI over 40. But I think there's a lot more work to do, but the BMI definitely influences how the virtual non-contrast can be used and the accuracy of it. We excluded patients here with a calcium score of 0 because if you image 0, that will lead to 0, and this was a problem with some publications, and it will inflate your number of the correlations. So these were all patients that had calcium actually in the coronary arteries. And I think the value is more when it's higher. If you have lower values of contrast, of calcium, that may be a little bit more tricky. But sometimes we work with Azim Latif in that he has a high volume of TAVR patients, and he always wants the coronaries to be evaluated in the CT. And this can be very challenging. So I think the use of monoes will help you decreasing that calcium so you can look a little bit better in the coronaries, or if the contrast is not appropriate, you can decrease the monoe to enhance the contrast. And the idea is that the use of these two will lead to a better scan. With the new scanner, in particular the Spectral CT 7500, it has a very fast table, so you can do also a non-gated chest, abdomen, and pelvis in 2 seconds, so it's a very fast scan. We have in the large system, we have some scanners that are newer, some scanners that are older, like I'm sure everyone here deals with the same problem. And when you have a slow scanner, a slow table, that can be a big problem for TAVR patients. So I think that the new scanner can aid on that, and the findings from the Spectral can help you get a good quality scan. We can see here a gated chest, abdomen, and pelvis with only 5 millisieverts, and I think this could be a very good add-on to the TAVR patients So that could add value to it. Let's talk a little bit now about the patients with atrial fibrillation. So these could be patients that were doing the scan for atrial fibrillation or the common atrial fibrillation, or they have a history of AFib, and we do a scan, and then we see something in the left atrial appendage. The idea is that the spectral values can also help you determine if this is actually slow flow versus thrombus. So you can use the iodine, no water, spectral results, and in that way quantify the content of iodine in the two different ones. As we can see there, one has a lot less content of iodine, and that's a thrombus versus the other one that is just smoke in the appendage. This is, I want to show you a case that is a real case, just filmed actually on the phone, but I think it just shows you how this can add value. This is from our CT. This was a delay that we did, and you can see very well there, but when you look at the iodine density, this is very obvious that there's a thrombus there. So I show this one again. I think you can probably see it's still there, but I think it adds a lot, makes it a lot more obvious that your technologists can hopefully see it, and your fellows can see it, and everyone can just know how to deal with this case afterwards. So I'll show another case. This is a 25-year-old that came to the hospital with chest pain. She had been admitted before with chest pain because she was young. She had some mild troponin, and she was actually discharged. She came with a little bit of higher troponin this time. We checked troponin 3 times that were mildly elevated, so we decided to go for a CT. We scanned the coronary arteries. As you can see, there's no significant plaque. And then we did delayed iodine as well. As you can see, it's hard to see, but you can see there's some delayed iodine in the inferolateral wall. But these are the best that we could get with the conventional, and trying to get the best pictures to show it for conference or to make a diagnosis. Now, when you come to the delayed C effective, that becomes very obvious. I think there's no question there that the myocardium is affected, and the location is also typical for viral myocarditis. We sent Coxsackie results, and it came positive. So this patient was saved from having an invasive coronary angiography that probably wouldn't have gotten the diagnosis. We could have done an MRI, but she didn't want to wait. There was a little bit, unfortunately, sometimes there's a little bit of higher wait for us for a cardiac MRI than for a CT. So the diagnosis was made. I think Spectral helped a lot to make the diagnosis here. And this has been studied by mostly a group in France of the value of a Spectral in patients that have myocarditis. We can see here they studied 20 patients. You can see the difference in time with MRI than with CT. I think you can do MRIs a lot faster than 40 minutes now, but still takes longer, and not every patient is a good candidate for the MRI. The CT can be 15 minutes, or you could be even shorter, I think, if you're doing it for myocarditis. And these were only 20 patients, but the patient-based sensitivity was 100%, and segment-based when compared to the MRI LG was 82%. But for those that do delayed iodine, you know that it's not always the easiest to get good pictures with the conventional images. So it doesn't always look as good as we see in many of the pictures. So Spectral, I think, like I showed you a case that it wasn't that nice with the traditional, but it looks very good with Spectral. So how to make the diagnosis from CT can be also a little bit challenging, but we can still do it. Unfortunately, we so far cannot image for edema, but we can find a non-ischemic myocardial injury using the delayed iodine, and potentially the use of the C effective values could show you something about edema, but that's not there yet, I think, to be said. But you can also evaluate for systolic LV dysfunction, and pericarditis, you can see an effusion, but it can be a little bit more challenging as well. So MRI still, I think, is the the go-to, but CT has a growing role in the diagnosis of myocarditis. And sometimes these patients have a little bit of troponins, and then first for a CT, if you can save the patient and your institution from having to do an inpatient MRI, I think that's probably the best. There's another case here. This was a 61-year-old male that came with hypertension and hyperlipidemia, came to the clinic. He was complaining of chest pain and shortness of breath, and this patient was sent for a PET. So you can see a stress PET, you can see in the top the stress, you can see in the bottom the rest. And for those of you that don't do PET, you can see there's a defect here in the mid to distal LV, and you can see it here in the plots as well. So what's the diagnosis? We know the patient went then afterwards for a CT. As you can see here, the patient has apical hypertrophic cardiomyopathy, and you can see with the delayed iodine, the concentration of iodine mostly in the area that is more hypertrophied. So I think in these patients with cardiomyopathy also delayed iodine can be of use. It's still a decision when to do delayed iodine, when to plan it, when not to plan it, so you need to know a little bit better of the patient and the indication in order to decide. We don't do it for every single patient, obviously. So as conclusions, we can see that Spectral CT can add significant value in the evaluation of chest pain. A dual layer detector allows for an always-on spectral result. We can have multiple spectral results that are available to suit best your scenario, as you don't always know exactly which one you will need. We know that you can salvage low contrast attenuation studies using the low mono-E, as I showed before, and this could be done for the pulmonary artery or for the coronary arteries. You can salvage studies with high CAC, stents potentially, and you can also use calcium suppression for patients with a high coronary calcium using the high mono-E. You can potentially obviate the need for a for the traditional calcium score. I think there's more research that needs to be done on this, but in particular in certain patients, this could be used to give you an idea of a burden of disease, and as we know now from the new CAD-RADS guidelines, also the value of putting in your report the burden of disease and the importance for the referring doctors to know how to treat this with all the lipid-lowering medications that we have and other therapies. We know that Spectral can enhance the perfusion defects and potentially the delayed iodine, like I showed in myocarditis, and we can do this with low mono-E's, and we can do this with a C-effective as well. And we know that it can add value in the left atrial appendage assessment in patients that are undergoing atrial fibrillation to detect left atrial appendage thrombus. Potentially, you could do delayed iodine there, but in my experience, this is at least hard to do with MRI in the atrium. So no one has done it, as far as I know, with CT. So I welcome you to our poster presentations here at SCCT. There are two fellows presenting, Javier Arce, who unfortunately didn't have any online picture, so I didn't put him there, but he will be presented on the influence of the BMI on virtual coronary artery calcium scoring, and he will also be presenting data on the use of thoracic aortic calcification to predict mortality in patients with LDL cholesterol over 190. And then Michael, who is another one of our fellows, will be presenting on the power of zero in a population with underrepresented minorities with chest pain. So thank you very much for coming. I hope you're as excited as me to finally be here in this meeting. So enjoy Vegas and the conference. Thank you.
Thank you, Dr. Slipczuk. The session is now open for questions. And maybe while we get any questions from the audience, let me start with one. So you explained how with this spectral detector being always on, the workflow for the technology scanning doesn't change much from conventional scanning. How about on the reading side? So, you go from getting only conventional set of images to more contrast and more reconstructions. Can you comment a little bit how is this affecting the reading practice, and how did that implementation and adoption go in your department?
Sure, I think there's two options you can go from this. So we have certain clinical indications where you can have preset spectral results. In that way, when your scan gets reconstructed, you will have those results. So we always do low mono-E's. So those come just with every single scan. So in case the scan is not good, the technologist can look at the low mono-E and see if that one came okay. So that's one option, and you can do this for the delayed iodine as well. For that one, we have the C-effective as well that can add value, or for the atrial fibrillation results. But also you have everything, so then you can either at the scanner or you can use it in IntelliSpace. You can reconstruct them and very easy switch from the different spectral results, so you can also compare all the different spectral results in one view. So then you choose the one that best fits for you.
Okay, thank you. You mentioned so salvaging suboptimal quality exams with those different types of reconstruction. So how does it impact the reduce of rescan in your practice?
Yeah, I think this is very important. For example, if you're going to be doing triple rule-outs, then it's extremely important because the radiation on these scans is high. So even if you're scanning just the heart afterwards, you don't want to give any more radiation. So we try not to do too much of the triple or quadruple rule-outs, but if it's going to get you to the answer, sometimes you have to do it, but you definitely want a diagnostic scan. So I think in those that's a lot because the timing can not be the best sometimes to get the pulmonary artery, to get the coronary arteries, and therefore the delayed. So I think there's a lot of value in those scans. But also if you're trying to reduce the iodine in patients that have a little bit of CKD and you want to give less contrast, I think in those also it will significantly affect the amount of studies that you get diagnostic.
Okay, thank you. So again, is there any questions from the audience? Here we have just one here.
Yeah, so that's a very good question, actually. So we do most of the measurements for the annulus. We do them with the traditional. We do those measurements. As far as I don't know about any studies that were evaluating the different measurements with different mono, because it will affect the value of your annulus. But I think it has a lot of value for the coronaries, and it has a lot of value for the peripheral arteries if you see a lot of calcification. And we don't do only TAVRs. We do, for example, also a lot of TTVRs with a SIM, and sometimes these scans also, patients with severe TR, the opacification in the right atrium may not be easy to do sometimes. So I think in those also it would add more value. And in those, I think you can look at the annulus a little bit better or see the structures better. But for TAVR, for the annulus, all the measurements we do, they're with the traditional.
Any other questions? Okay, maybe a little poll by the show of hands. How many of you are using spectral or dual energy in your cardiac practice?
Yeah, 1.
3. Okay.
All right, if you have any questions afterwards, feel free to reach out, or you can send me an email. My email is there, or Twitter, or whatever way you want to approach. I'll be happy to answer it. Thank you very much.
Okay, thank you for your attendance, and thank you, Dr. Slipczuk.